I want to tell you about a patient. 76 years old, sharp as a tack, rode his stationary bike every morning, lived alone, fully independent, came in for a routine checkup, left with a referral, then another, then a procedure, then a complication. 3 months later, he couldn't get up from the couch without help. The original problem, it never would have touched him. The testing did. I'm Dr. James Mercer, cardiothoracic surgeon, 15 years operating on the human heart. And what I just described, I've watched it play out more times than I want to count. This is the conversation that almost never happens in a 15-minute appointment. The one your doctor genuinely may not have time to have with you. The one that could change how you think about every single medical decision you make from here on out. So stick with me because this one matters. Here's something nobody tells you clearly enough. The math changes after 70, and the medical system hasn't fully caught up yet. When you were 50, early detection made complete sense. Find something small, treat it fast, add decades to your life. That logic worked. It still works great for 50-year-olds. But somewhere along the way, medicine forgot to rewrite the rulebook for people who are 707580. Here's the uncomfortable truth. The same screening that could buy a younger patient 20 extra years of healthy life might only buy you 2. In those 2 years, they might be spent going from appointment to appointment, recovering from procedures, not actually living the life you worked so hard to build. Think about it this way. Cancer doesn't always behave the same in an older body. Some tumors grow so slowly that a 5-year-old will simply die of something else long before that tumor ever causes a single symptom. Finding it doesn't save them. It just gives them something to worry about and a doctor something to treat. Once something is found, the machinery starts moving. Your doctor feels obligated to act. You feel scared not to. And suddenly, a healthy older adult is on a table under anesthesia for a problem that was never going to hurt them. This is what we call the Cascade effect. One of the most underappreciated dangers in modern medicine. It starts innocently. A routine scan. A borderline result. Let's just take a closer look. Sounds reasonable, right? That closer look finds something else. That something else needs a biopsy. The biopsy causes a small bleed. The bleed needs monitoring. The monitoring picks up an irregular heartbeat. The heartbeat needs medication. The medication causes dizziness. The dizziness leads to a fall. I've watched this chain of events play out more times than I can count. A perfectly functional 72-year-old walks in for a checkup, and 4 months later, she's managing 3 new diagnoses, 2 new prescriptions, and a fear of leaving the house she'd lived in for 40 years. Does every test lead there? No. But the risk is real, it's documented, and it is almost never part of the conversation when a doctor slides that referral slip across the desk. So let's have that conversation right now. 5 tests still being routinely ordered for people over 70, and why you need to ask some serious questions before you just say yes. Let's start with one of the most common procedures ordered for older adults, the colonoscopy. For people in their 50s and 60s, genuinely valuable. It finds polyps early, it prevents colon cancer, it saves lives. The data on that is rock solid. But after 75, the math starts shifting. Here's what the research actually shows. Colon cancer is one of the slowest moving cancers we know of. From polyp to dangerous, we're typically talking 10 to 15 years. So if you're 76 and a colonoscopy finds a small polyp today, the realistic chance of that polyp ever causing you serious harm in your lifetime is actually quite low. Now here's the other side of that equation, the side nobody brings up when they're handing you that prep kit. The procedure itself carries real risks for older patients. That full bowel cleanse the night before can cause serious dehydration. For a 70 or 80-year-old, electrolyte imbalances aren't just an uncomfortable night. That's a genuine medical event that can land you in the ER. Then there's the sedation. Older adults don't metabolize anesthesia the same way younger patients do. Research points to temporary and in some cases lasting cognitive changes following sedation in patients over 70, and there's a real risk of bowel perforation during the procedure itself. In a younger patient, that's serious. In a frail 80-year-old, it can be life-threatening. So before you schedule, ask this one question every single time. If we find something, what are we actually going to do about it? Because if the answer is probably nothing aggressive, then why are we doing the procedure in the first place? The American Cancer Society updated its guidelines on this. Colonoscopy after 75 should be individualized, weighing your overall health, your life expectancy, your personal preferences, not just automatically put on the calendar because it's been 5 years. Does your doctor have that conversation with you? Or do they just hand you a referral and tell you to call the scheduler ask every time? This next one is harder to talk about because cancer screening feels like the most responsible thing you can possibly do, and I get that. I genuinely do. The fear of cancer is real. The instinct to catch it early is deeply human. I've sat across from enough patients to know exactly where that comes from. But here's what 15 years of medicine has taught me. Finding a cancer and helping a patient, those are not always the same thing. Let's talk PSA testing first. That's the blood test used to screen for prostate cancer. In men over 70, PSA frequently detects slow-growing cases that would never have caused a single symptom. These are sometimes called, pretty bluntly, cancers you die with, not cancers you die from. But once that number comes back elevated, the cascade kicks in. Repeat testing, then a biopsy. The biopsy carries its own risks, infection, bleeding, and a level of anxiety that genuinely affects quality of life. And if cancer is confirmed, the pressure to treat becomes enormous. Surgery, radiation, hormone therapy. Each of these comes with serious side effects: incontinence, impotence, fatigue, bone loss for a cancer that was just sitting there quietly going nowhere. The U.S. Preventive Services Task Force recommends against routine PSA screening for men aged 70 and older, not because the issue isn't serious, but because the harms of detecting it at that age frequently outweigh the benefits. Same basic idea applies to mammography after 70. Breast cancer screening finds tumors, but a significant portion are slow-growing, hormone-sensitive cases that are unlikely to ever spread aggressively. And yet finding them on a mammogram often triggers the full treatment protocol. Surgery, radiation, sometimes chemo. I've seen women in their late 70s go through the surgery, the recovery, the reconstruction. All of it took a year of their life. A year of pain, limitation, and fear. For what? Now I want to be really clear here. Some breast and prostate issues after 70 are genuinely dangerous. This is not me saying don't ever screen. This is me saying have an honest, individualized conversation before you agree to anything. Before your next screening, ask, if this test finds something, what does treatment actually look like? And what are the realistic risks of that treatment for someone my age and my overall health? If your father had a PSA test last year and the number came back elevated, call him this week. Ask him what they said would happen next. The answer might shock you. Let me ask you something personal. Have you ever had a cardiac stress test? Maybe you walked on a treadmill while they had electrodes stuck all over your chest. Maybe they gave you medication to simulate exercise. And maybe the results came back with something, a flag, an irregularity. We should probably take a closer look at this. If you're over 70 and you've got no symptoms, no chest pain, no shortness of breath, no dizziness when you're going about your day, that test may have opened a door you really didn't need to open. Here's the problem with stress testing in asymptomatic older adults. The test has a high false positive rate in this population. It frequently flags something that looks like a problem on paper but isn't actually causing harm. And once that flag goes up, the next step is almost always cardiac catheterization. That's where they thread a thin tube into your arteries to get a closer look at the heart. The risks are real: bleeding, arterial damage, kidney stress from the contrast dye, and a small but genuine risk of stroke during the procedure itself. All of those risks go up in older patients. Here's what should give everyone pause, and this comes from multiple large studies. In patients with stable coronary artery disease and no symptoms, stenting and bypass surgery did not reduce the risk of heart attack or death compared to medication alone. Let me say that again, because it really matters. For stable, asymptomatic patients, opening up the arteries surgically produced the same outcomes as simply taking the right medication. Same results. No operating table required. So what should you focus on instead? The stuff with decades of solid evidence behind it and zero procedural risk. Blood pressure control, cholesterol management, not smoking, staying physically active. These aren't flashy, but they work and they won't land you in a cath lab. Hip fractures in adults over 80 are genuinely dangerous. Research suggests up to 30% die within a year from related complications. That's not a stat I throw around lightly. So yeah, of course we want to prevent fractures. Bone density absolutely matters. But the way we're going about it after 80 isn't always helping as much as we think. DEXA scans, the standard test for measuring bone density, are widely used and pretty straightforward. The scan itself is harmless. That's not the issue. The issue is what happens when the numbers come back low. When a DEXA scan shows osteoporosis in an 1-year-old, the near automatic response is to prescribe bisphosphonate medications. These drugs slow bone breakdown, and in the right patient at the right time, they're helpful. But in very elderly patients, the picture gets complicated fast. They can cause serious GI issues, including esophageal irritation, and long-term use carries a paradoxical risk called atypical femoral fracture, where the thigh bone actually breaks due to oversuppression of normal bone remodeling, a medication designed to prevent fractures, contributing to 1. So, what actually prevents fractures in older adults? The evidence here is pretty consistent. Muscle strength, balance training, making your home safer, grab bars in the bathroom, non-slip mats, better lighting in the hallway, reviewing any preventives, medications that cause dizziness, getting enough vitamin D, enough protein. These interventions prevent the fall. Preventing the fall prevents the fracture. A DEXA scan won't tell you to put a grab bar next to your shower. It'll give you a number, and that number will probably trigger a prescription. If your doctor orders a DEXA scan, make sure that conversation leads to fall prevention first. Medication second. Ask straight up, what are we doing to keep me strong? That's the right question. Now picture this. You're 74 years old. No symptoms. No dizziness. No weakness on one side. You feel completely fine, normal Tuesday, nothing unusual. But your doctor orders a routine carotid artery ultrasound. That's a scan of the blood vessels in your neck that supply blood to your brain. The scan comes back showing 70% blockage on one side. Now everybody's alarmed. You're getting referred to a vascular surgeon. There's a recommendation to operate. Here's what nobody tells you clearly enough. For asymptomatic patients, people with zero stroke symptoms, the evidence for operating is genuinely weak. Multiple major trials have shown that the risk of stroke during the procedure itself can equal or even exceed the annual stroke risk from just leaving the blockage alone with optimized medication. Read that again. The surgery meant to prevent your stroke could cause the very stroke it's trying to prevent. And yet carotid screening keeps getting ordered routinely, partly out of habit, partly because finding a narrowing feels responsible. The American Heart Association guidelines are clear. Routine carotid screening in patients without symptoms is not recommended. And yet it happens every day in clinics all across the country. If your doctor suggests this scan and you've got no symptoms, ask directly, what are we actually going to do differently if this comes back abnormal? If the answer points towards surgery, ask about the procedural stroke risk. Then ask about the risk of just optimizing your medications instead. You deserve both numbers side by side before you make any decision. I know what some of you are thinking right now. All right, so should I just stop going to the doctor altogether? Absolutely not. Please don't do that. What I'm describing is a shift in focus. Not less medicine, different medicine. Medicine that's actually designed for where you are in life right now. After 70, the most important medical goals genuinely change. The focus moves away from hunting down every possible abnormality and toward protecting what actually matters most. Your function, your independence, your cognitive sharpness, your ability to wake up in the morning and live on your own terms. Blood pressure management stays critically important at every age. Uncontrolled hypertension damages your brain, your heart, your kidneys. The evidence is clear, and the treatment works. Cholesterol management still matters, especially if you've got existing cardiovascular disease. Vision and hearing checks are genuinely undervalued in older adults. Poor vision is a major fall risk. Untreated hearing loss is now linked in multiple studies to accelerated cognitive decline. And most insurance, including Medicare, covers these. Don't sleep on them. Diabetes management, vaccinations, flu, pneumococcal shingles. These are low risk, high benefit, and evidence backed. Don't skip them. And maybe most importantly, a thorough annual medication review. Polypharmacy, meaning taking multiple medications at the same time, is one of the most dangerous and underappreciated risks for older adults. Ask your doctor to go through everything you're taking every single year and justify each one. That conversation alone could genuinely change your life. This is what proactive medicine looks like after 70. This is medicine that's actually working for you. Here's the hardest part of everything I've talked about today. None of it matters if you can't actually have this conversation in the exam room. I know it feels awkward. You don't want to come across as difficult. You don't want to seem like you're refusing care. But I need you to hear this. You are not refusing care when you ask questions. You're participating in your care. There's a profound difference between those two things. When a test gets recommended, ask, what exactly are we looking for and what will we do if we find it? That one question forces a real conversation before you're committed to anything. Ask, what's the risk of this procedure for someone my age and my health situation? Age-specific risk is rarely volunteered. You have to ask for it. Ask what happens if we just watch and wait instead. Active surveillance is a completely legitimate, evidence-supported option. It's not giving up, it's choosing wisely. Ask, is this guideline based on research that actually included people my age? A lot of guidelines were built from studies of middle-aged adults and just extended upward without specific evidence for older populations. And if you want to cut right to it, ask, what would you recommend if this were your own mom or dad? I've asked that of colleagues. The answer is almost always different from the standard recommendation. Now, I do want to be fair to your doctor here because this matters. The system they're working inside isn't designed to support these conversations. A typical appointment is 15 minutes. Ordering a screening takes 30 seconds. Having a real nuanced, individualized conversation about whether that screening actually makes sense for you specifically that can eat up the whole appointment. Time that often just doesn't exist. That's a systemic problem. But you can work around it. Write down your questions before you go in. Ask for a longer appointment if you need one. Most practices can accommodate that if you give them advance notice. Bring someone with you who can help you advocate. And if your doctor dismisses your questions instead of actually engaging with them, that tells you something important about whether that doctor's the right fit for this stage of your life. You've spent decades trusting medicine. Medicine owes you honesty in return. You deserve a real conversation, not a rubber stamp and a referral slip. I've been a cardiothoracic surgeon for 15 years. I've held a human heart in my hands. I have deep, genuine respect for what medicine can do. The procedures I perform every week save lives. Real lives. People who go home to their families, who get to see their grandkids grow up, who get years they wouldn't have had otherwise. And that is exactly why I'm telling you this. Because I've also stood at the bedside of patients who didn't need to be there. Patients who came in healthy, active, fully independent, and left diminished. Not because their disease finally caught up with them, because the system did. There is a moment in every one of those cases that haunts me. It's the moment before the first test, when the patient was fine, when the cascade hadn't started yet, when there was still a choice on the table. That moment right there is what this video is about, giving you that moment back, because right now you still have it. Here's the one thing I really need you to walk away with. More medicine is not always better medicine. After 70, the goal shouldn't be to find every possible abnormality in your body. The goal should be to keep you strong, clear-headed, mobile, and living fully on your own terms. Those are not the same goal. And confusing them is costing people their independence, their dignity, and sometimes their lives. You are not a collection of numbers on a scan. You are not a list of findings on a lab report. You're a person with a life, with people who love you, with mornings that matter, with everything still worth protecting. Every medical decision should be measured against that life. What does this test actually change? What does this procedure protect? What does it cost in recovery time, in risk, in everything if something goes wrong? Ask those questions. Demand those answers. Because nobody else in that exam room is going to ask them for you. The moment before the first test, when the cascade hasn't started yet, when there's still a choice, that moment belongs to you. Don't let anyone take it away. Let's bring it all together. 5 tests worth a serious conversation before you say yes. Routine colonoscopy after 75. Weigh the real procedural risks. Prep complications. Sedation effects. Perforation risk against the realistic benefit for your specific age and health. Ask what actually happens if something gets found. PSA testing and mammography. Before you screen, ask what treatment looks like. The cascade is real. Understand it before it starts. Cardiac stress testing without symptoms. Know that finding something may lead towards surgery, and the evidence shows that surgery often doesn't extend life beyond optimized medication alone. DEXA scanning after 80. Make sure the conversation leads to fall prevention first. Grab bars and balance training prevent fractures. A number on a report triggers a prescription. Carotid artery ultrasound without symptoms. Ask for both numbers, the procedural stroke risk and the risk of doing nothing. Side by side, you deserve both before you decide anything. None of this means avoid your doctor. It means go in prepared. Go with questions. Know that you have every right to understand exactly what you're agreeing to and why. Here's what I want you to do today. Write down 2 or 3 questions from this video. Bring them to your next appointment. Read them out loud. See what happens. Then come back and tell me in the comments, has a doctor ever ordered a test that led somewhere you really didn't expect? I read every single comment. Your experience matters, and it might help somebody else make a better call at exactly the right moment. If this video helped you think differently about any of this, share it. With your parents, with your spouse, with anyone you care about who's over 70 and still just going through standard screenings on autopilot because that's what you do. The people who need this conversation most might literally be sitting in a waiting room right now. Subscribe to Healthcore, because this is exactly the kind of conversation we show up to have. Real information, real science, no agenda. Just the truth about what actually helps you live better, longer, and on your own terms. Everything I've shared today is general medical information based on current published research and my clinical experience. Your situation is unique. Your history, your health, your values, all of it matters. Before you make any changes to your care, please talk with your own physician who knows your full picture. That conversation is always worth having. I'm Dr. James Mercer for Healthcore. Stay strong, stay informed, and stay in charge of your own health.